in listen-only mode.
Good evening, Rich. How you doing?
Hey, Guy. I'm doing well, thank you.
Just
Welcome, guys. Thank you for joining us on a Tuesday evening in February of 2019. If you're going to quote us, please remember that's the day we're recording this because as we talk about billing, it changes. What do you think, Guy? At least month by month, if not week by week, anyway.
yeah, we did this webinar maybe probably 9 months ago, and I went back to the old PowerPoint, and it's different. I mean, this is a moving target, especially when we're talking about out-of-network billing. We're going to talk a little bit about billing in general, but out-of-network billing is absolutely a moving target, and we're going to talk about some techniques to help you succeed at that. If you like to have any questions, we'll get to all of them before the night's over. Type them in the question box, and we'll be happy to answer them. We have our whole team of dental sleep medicine experts who help us out at DS3, and they'll be answering them. Rich and I will get to them too, so type them in that question box. So the 4 pillars of dental sleep, this is what we've been preaching as long as I can remember: screening, testing, treating, and billing. If you have those in place, you can make your practice go to whatever extent you want in dental sleep. The last one being billing. And that's what we're talking about today.
We got to get paid.
Yeah. Is this one of your team members in your office, Rich, is carrying around the insurance burden?
I think, I just taught a course last weekend at Ohio State, Guy. This is always a big topic. We know this anytime we get in front of dentists. And, I think for those of you who do dental sleep and general dentistry, this is much more of an issue. There aren't many of us that do just sleep, but remember, your staff probably feels overworked already. And when you start talking about doing dental sleep medicine, and now we're going to do medical billing, that's what we say. I mean, the short answer is good luck. I hope it goes well, but there's more to it than that.
Yeah, and really what we want to emphasize here is dentistry is what we do as dentists and our team members. And when we look at root canals, implants, fillings, cleanings, injections, we're all comfortable with that because we do those every day. Our teams are used to it, even though it makes people outside the dental area cringe. It's what we're used to. And if we were to ask one of you hey, the pilot's not feeling well, he had the chicken or whatever. I watched Airplane from the 70s the other day, and comes back and says, "Look, you didn't have the chicken. Can you come up and fly this plane?" It may not be the best day going on right there for you. If you get sued, you have to have your attorney help you out, and or CPA, or you're gonna do your own taxes. And the point being, you don't know how to do those things because you weren't trained to do them. You can learn how to do them, but why would you when you should do what you need to do? And just because you have John or Jane or this insurance guru in your practice who's the dental insurance guru, it does not equate to the insurance medical billing guru, because it's as different as apples and oranges, and you likely need help with that. We can help do this. We have partners that do this, including some of our own subsidiaries. We're not just going to end the webinar and say, good luck, goodbye, we're done. I mean, there's a lot to do in spite of just the billing itself. But if you try to do this on your own, it's just not going to work out. And the good news is we have help now. I mean, when we started doing this, Rich, there was no medical billing because we didn't get paid. And once we started getting paid, there was no one to help us. And now we have great help to do this. So any more on that, Rich, Dad?
No, we didn't know who to call. There wasn't anybody. We didn't even have a code we could bill for.
Right.
We were all talking about, hey, which code did you try last week? Did you try this one? Did you get paid? So yeah, it's changing. So those of you who are getting into this right now, it's still not easy, but it's easier than it used to be. And I'm almost starting to sound like an old guy, aren't I? You guys don't have it as hard as I used to have it. So
well,
anyway,
that's true.
We want to help you figure out a better way to do this. That's what tonight's about.
And over the last year, I'm going to talk a little bit more maybe in some ways than Rich, because Rich does some in network, some out of network. My practice is strictly out of network. And I've done 4 things differently that I think's helped my out of network billing. One is not always accept an assignment of benefits. We have a couple of options. We have provisional options, and we don't always jump to the gap coverage. And I'll go into those a little bit for you. But just so everyone understands that there's a little checkbox on your medical insurance for the 1500 or DS3 in the patient info section. Whoever's going to file the insurance, you need to know, are the checks going to go to you or the check's going to go to the patient? If you accept assignment of benefits, then the checks are coming to you. But also, there is a little fine print to that. If you accept the assignment of benefits, then you are agreeing to the insurance policies and procedures, even as an out-of-network billing to some extent. So, it comes with a little bit of an added obligation. Bag. So I don't think we always about this. We all had the check come to us. So when you don't accept benefits, the checks go to the patient. Now, you collect money from the patient, and they can stiff you if you don't have proper procedures in place. But most patients are honest. And now we don't have patient. We're billing procedure. So in certain situations, we still accept assignment of benefits, but in cases I don't. We discuss payment options with the patients. We talk about what we might expect yet. We're going to go into that in a little more detail in a little while. But at the end of the day, we weren't accepting their parameters, nor did we get paid by them. It makes us a little risk for audits on the road. And
you know how I remember that guy?
Yes, I remember.
I always had a hard time. Always have a hard time remembering that, and I always remember it now as, do I get the check or not? So it's box 27 on the CMS 1500 form. So if I know, then I don't get the check. That's how I always remember it, because I had a hard time remembering that for some reason. I don't know if that was just me, but
that makes sense. The checks are going to come to you, but you also accept the responsibility that comes with that. I think that's another way of thinking about it. You accept the check, you accept the responsibility of now to partner with it. And the last option, I think, Rich, you've taught me this years ago, and we've been using this for a while, but we've really just more formalized that I want everyone who comes in our offices, Rich, I mean, they come in your office, a lot of times we're their last hope, aren't they? I mean, you saw, I was there in your office last week. Wow, what a fun time that was. I spent time in San Antonio, and I saw on the board 71 devices they did for the month. That's pretty impressive. It was great to see, but our goal is to treat these people, right, that they need our help. And if for some reason they don't have good insurance or they can't afford their co-pays, and if we can't do anything else for them, I think it's a great thing to do for these patients is to make them a temporary, what we call it in our office now, Rich, is a custom fit transitional device. Kind of sounds cool, but I mean, it's what it is. We custom fit this, and we're going to transition you to the more permanent device down the road. And it gives them an opportunity to hopefully see if this thing works for them, for their symptoms, gives them some immediate care. And for those patients who aren't ready to commit to a more full treatment now, most people who come in our office, we have an options that will fit within their budget. And so we're not seeing patients for consults who ultimately don't get treated.
I like that. The old CFTD.
Okay.
Custom fit transitional device.
No, good.
We just need another acronym for dual sleep medicine, don't we?
Yeah. Yeah, use your own terms, but we use a MyTap. We're big fans of Airway Management, and I like the MyTap in our office. So
I like that. You know, you can charge more with better names. You know, that's a well-known fact.
Right. A little housekeeping. Go ahead, Rich.
You're going to get your CE, so don't bug us. You know, give us a couple of days to get it to you. Make sure that you check your spam filter. You know, we send out a lot of emails, and sometimes that stuff goes into spam. So, a week from now, if you don't get it, you can bug us, but make sure you check your spam folder first, and we'll get it to you. So, Guy and I've been doing this a long time. We met quite a few years ago. We're both got about 20 years doing this now. And, we know a lot about this, and we tease each other because we made a lot of mistakes along the way. It's always asked me how I know. We made those mistakes. So we really feel like we have our finger on the pulse of what's going on. We get to work with a lot of dentists. We get to be in front of a lot of dentists. We do a lot of training. We do a lot of webinars. We do an awful lot of things for free for the industry. And that's because Guy and I are both passionate about trying to move the needle. We only have 3 or 4% of the market share in the entire United States for sleep apnea treatment. And we're really trying to change that. And we really feel like, because of people like you who are on this webinar tonight trying to figure this out, and you're listening to us and you're taking this stuff to heart and you're actually going out there and putting it in practice, that we really are starting to move the needle now. And that's a good thing. That means that more and more people are being treated. We should all feel good about that.
Yeah, and that's why we get up in the morning. That's why Rich and I, pushing 10 years ago, decided to start Dental Sleep Solutions. And, people ask us what we do. What we do is we help dentists help their patients get treatment for sleep apnea and sleep disorder breathing. We help you put the systems in place, screening, testing, treating, and billing, and we help you with education, coaching, software, and support. If you want to know more about what we do, or even if you just have a question that, I just wish I had the answer to this question, just type in consult or call us next week. Type in consult. One of our trainers will meet with you, answer your questions, and, we'll give you some free advice, because that's why we get up every day. We're real excited about this weekend. If you're not registered, it's probably too late, but it's not too late for 2020. We got great weather here in Florida, Clearwater coming up. I looked at the weather map here just a little while ago. I'm really excited. Rich, you're coming down when, Thursday?
Uh-huh.
Yeah,
my whole staff's coming. We got a whole entourage coming to Florida. So, a lot of good speakers lined up. What we love about this is we really work very hard. I say we, mostly it's the team at Dental Sleep Solutions that does this, but we all work hard to bring you a lot of practical information. We really pride this on being a meeting that you can take home a lot of pearls. You go and you learn how to do this little thing or that thing, or you learn how to do this and that. I think it's important that we understand the medicine behind sleep, Guy. And when you look at other meetings that are put on, we get a lot of that type of information, and that's all good. There's nothing wrong with that. Knowledge is power. That's what I always say. But we do a lot of practical stuff, and these are all 1-hour talks, except for the breakout sessions, some of which are quite a bit longer. One of which I think we're doing on billing as well there, right, Guy?
I think there is still some room in the billing. I think the rest of the symposium's about full. That's a full day on Saturday, this coming Saturday in Clearwater. We're sold out, I think, at about 500 attendees. As far as we know, it's the second biggest dental sleep meeting in the country. So Clearwater Beach this coming Friday and Saturday. If you can't make this year, look forward to the reviews, because they'll all be really, really high reviews, and trying to make it next year. We do courses all throughout the country, and the only time we give these $200 off tuition is if you watch these webinars. So we don't just hand those out. Otherwise, if you want to come to a hands-on 2-day course where you get a sleep test to the doctor and a dental device delivered, it's normally $9.95, and you can bring your team member. You can get $200 if you just type course. Doesn't obligate you, but it secures that $200 off, which is worth the price of admission just in the sleep test and the dental device. So we'll put that up again at the end. We're always adding to these as well. So we want to get to the one last thing that you're doing, Rich, and get to billing, because I know it's what everybody's on here for. We're doing these advanced courses. You want to talk about those briefly, Rich?
Yeah, Keith Thornton and I, Mark Fowler joins us from Bullseye Media, and a lot of if you've done, I don't know, what do you think, Guy? At least 50, maybe, or more dental devices. I think you're at a point where you're going to have a lot more advanced questions than the dentist who says, "Hey, this is my first one. How do I do this?" We've all been there. We all started there, didn't we, Guy? You and I both started, doing one device at a time. So we're doing one in into April and end of October. We limit those to, I think, about 25 or 30 people. So
Right.
we like that. That we found that that's about the biggest size that we can accommodate for being really hands-on like that. And it's great. We did our first one last year, and it went over very well. So
Very
I'm
well.
looking forward to
Keep
those.
forwarding it. I just got have heard nothing but positive reviews. If you want a really great hands-on course, and then Tuesday, March 12th, we're going to do something we haven't done in a long time. So it's going to make me do some work to put together a PowerPoint here. But really, what do you want to grab out of a sleep test? What are we looking for? How do I look at a sleep test? We're going to review sleep tests, what the lines mean, what we're looking for. So it's going to be exciting. It's something we haven't done in quite some time. So that's March 12th. Again on Tuesday night. So let's talk about medical billing now, and let's talk about the differences here. And we're going to get into the out-of-network here very shortly, but just at a high level, I want everyone who's anyone new on this on a webinar tonight to understand the moment that you bill an E0486 code, when you bill out a dental device for an apneic patient, you are now doing a medical procedure with a dental device there, and everything's different. It's totally different rules, and it's just different than what you're used to. We have a lot of things on the screen here. I'll just hit a few of them just so we can make sure that we stay on time. I think the key one on it is that diagnosis isn't required for dentistry. You can just do a DO composite. You don't have to say, what's the diagnosis code? Distal decay. We have to have a diagnosis. It has to be by a physician. Everything's determined by paperwork in medicine versus radiographs in dentistry. Audits are different because they come after the fact. We do SOAP notes versus progress notes, and even the forms we use are different. So there's a whole lot of difference between medical and dental billing. And in dentistry, I think, too, just the way we think about this, I think even if you don't have a fee-for-service office where the patients pay you and the insurance check goes to them, or you don't even mess with insurance. Even if you rely heavily on insurance, you pretty much say, here's the fee, and the insurance pays the difference, and that's that. In medicine, man, write-offs are just, kind of rampant, I guess even is right word. They're everywhere. They're expected, and so the fees are higher because they expect write-offs in the office, and even the codes of ethics are a little different. So the ADA says that if you write off these third-party payments, so instead of insurance payments, without disclosing those. So in other words, someone comes in for a crown and you just take the insurance and don't collect the full balance. That's wrong. Have you heard that before, Rich? That
every dentist in the entire country has heard that. Guy came up with these things right out of the ADA Code of Ethics. And I think if you're not sitting down, you should sit down for the next slide. Because, now when we look at the AMA Code of Ethics, where patients are made more conscious of healthcare through their co-payments. And then when a co-payment's a barrier, we should waive the fee. Right. I mean, which one do we want to go by here, Guy? Are we a dentist, or are we acting more in medicine when we do that? We have a dental treatment, but we're filing a medical code in for a medical diagnosis.
And medical insurance. We're filing it with medical insurance. So that's why I believe we have to go by the medical code of ethics more so than the ADA, because we're doing a medical procedure and billing medical insurance, which is the most important part. So, and really, we want to get to your questions here about this, and we're going to go through how you do this fee for service, different methods. You don't have to do this, is the good news. You can go back and screen your patients, find the ones who have been given a CPAP and can't wear it, find patients who've not been diagnosed, facilitate that, and they'll pay you to do a dental device if you have patients who trust you and believe with you, and you have patients who can afford to pay you. But what won't happen is if you want referrals from the physicians, you can't really get much traction unless you deal with medical billing. The physicians aren't going to refer to you. The first question they're going to ask is, how much do you charge for this? Does Medicare cover this? Do you accept insurance? I know, Rich, you meet with 2 or 3 physicians a week, right? Is that one of the first or second questions they ask you?
Pretty much. Usually it's the first one after, what did you bring us for lunch? But and if you don't if you don't get this, I'm just telling you, it's almost like, it's like, guy, I have a beer occasionally, as you know, but I'm not an alcoholic. But if I'm going to tell an alcoholic how to get his life together, he won't listen to me because I'm not an alcohol. I'm not a recovered alcoholic.
Well,
That's almost like what this is. It's almost like the physicians are like, hey, if you don't do this, you're not a member of the club,
right.
and therefore we're not going to do it. And I really think that's because of a couple of reasons. Number one, they care about their patients. They want their patients to be treated, but they've also learned to play the game where they write that stuff off. And I think sometimes they resent that dentists don't have to deal with some of that stuff as much as they do. But I think at the heart of this is really, man, I care about my patients. When I send them over to you, Dr. Yatros, and you tell me it costs $3,000 and insurance doesn't cover it, and they won't pay anything.
Right.
And then my patients come back. That makes me look bad as the physician.
Absolutely.
So
Absolutely.
you just remember this. It's not impossible to have a good dental sleep practice if you don't do this. But I think if you want to build this in a long-term, very successful big model that has bigger reach in your community, you have to think about this and do it.
Yeah. And I'm not going to spend a ton of time on this slide. And if someone wants any of these slides or wants any information that we go too fast on, then just reach out to us or contact at the end of the webinar. We'll be happy to supply it. This webinar is going to be on our YouTube channel as well. But what you bill and what you want is not always the same thing, depending on your billing model. We're going to get into in a minute. And so I think one of the first things you have to sit down with, and this changes, the better you get at things, the more efficient you become, maybe the less of a fee you need, or the overhead goes up, you need more of a fee. But fundamentally, your office needs to decide how much I would like to have in my bank account for each one of these devices I do to make me be able to pay my staff, pay my overhead, pay myself, and be happy to go to work every day. And that can't tell you what that is because that's different for every office. So, if you know your overhead and know how to do that, great. If not, pick a procedure that you do and like to do. Kind of figure out how much time it takes you and lab bill. So you could pick something like a crown, maybe it's $1,300, and it takes a couple of hours of chair time and an hour of doctor time. In that case, if their lab bill is $300, then you're getting $1,000 for your time, doctor, for that time, or the chair time you can go by. And we have some numbers here you can kind of look at, but you should be able to do this in under an hour of doctor time with proper systems, as we can teach you at DS3, and maybe 2 to 3 hours of team time if done properly. So you can kind of back in to those numbers and figure out what fee you would like to have. And depending on your billing model, we can talk about actually how you bill that here in just a moment. There's decisions you have to make with this. So are you going to be fee for service? Okay, that's one decision. Then we don't have to decide on these others. But are we going to accept Medicare if we want to go down the insurance path? Are we going to be in or out of network? And if you're in or out of network, are we going to bill all codes? Are we going to bill different codes? What kind of a system are we going to do? And we've already established this is a medical procedure, not a dental one. So, Rich, you're in network with a few medical insurance carriers. What are the advantages that you see and disadvantages in network?
Well, you got to contact, somebody in provider relations as you do this. So again, we're going to talk about when you do in network, when you do out of network, and all that kind of stuff. So it can be difficult. Some parts of the country, I think a lot of us who've been doing this for a long time have made it a little bit easier because now they may have contracted with multiple dentists. So it is a process. You fill out their form and then you negotiate a fee. But again, you're signing a contract. It's just like you said before, Guy, when you said you accept assignment or not. Think about this the same way. Once you check that box that you accept assignment, it's almost like you signed this contract when you do that, because you're agreeing to all of that stuff, some of which you may not even know. That's another reason why we don't like to check that box, unless we know exactly what they're going to pay. But, the real advantage, though, is, number one, I don't have to guess what the patient's copay is. So what you don't know yet, because we haven't got to that part. I'm sorry, I'm stealing part of your thunder here, Guy, for the rest of the presentation. But one of the biggest challenges billing out of network is we don't know what they're going to charge. So in this particular instance, we know that the patient sorry, thank you, sorry about that. So, when the patient asks me, what does it cost? I can give them an answer. I can say, yeah, I can say, we called your insurance company. You met this much of your deductible. This is the remaining. Your 20% of, is $902 or whatever it is. We know.
Right. And the negative is that typically allowable amounts are less than out of network. So the contract that you negotiate is probably going to be less than the amount they'll allow, even that we don't know out of network. And the advantage, though, is that in network, a lot of people have less deductibles and less copays as well. So those are the advantages, and it's a big process too. And to be clear, everyone here, if you've not done something, then almost assuredly you're not in network, so you're out of network by default. And that's what we're talking about, Brian. Go ahead.
Yeah, let me add one more thing to that, Guy, too, as an advantage. Because I am in network, we'll get a patient, they go to their dentist and they want to make them a sleep device, and the dentist says, hey, let's get your insurance to cover this. And insurance says, no, we're not going to give you a gap exception. We're not going to give you that to that dentist because Dr. Drake's in network and he's here in town. So that might be an advantage too.
Yeah, and one of the things I mentioned that we're changing now is we don't always go for gap coverage, and I'm going to talk about that in just a moment. So the rest of what we're going to talk about primarily is out of network here. And why don't we all just go in network? Well, there's a hassle to it. It's the reimbursement can be very, very low to lower. They don't always let dentists in, and by default we're out of network. The big advantage to out of network is the allowables can be way higher. They can be 2, 3, 4, 5, 10 times higher that they actually allow. You're not obligated to go by the insurance rules, so you don't have to accept their amounts if you don't want to. And it's an easier process as far as you can get up and running tomorrow once you get some minor credentialing done that we can talk about that your third-party billing companies can do for you. The big disadvantage is they won't tell you the allowable. And I think I want to emphasize this. Rich already let the cat out of the bag. But if you're in dental billing, you can send a pre-authorization in and say, I'm going to charge X dollars for this bridge or crown. And they'll tell you if they cover it, if not, how much they allow. Oftentimes, they will not tell you as the dentist, as the biller, or the patient. So that you will never know what the allowable amount is until you've already billed the patient after the fact. And then it comes back and says, okay, you billed this amount. We only allowed this amount. And sometimes it's what you billed and sometimes it's not. And there's ways of, some medical billing insurance companies can help you guesstimate that better, but still yet you're not going to know it. So that's the big caveat. I think that's where people really get in trouble with out of network billing because they don't understand that one simple thing.
Let me ask you a question there, Guy. Why do you think that's where they get in trouble? So let's assume that they understand it somewhat, but I think you mean more than they don't just understand it. Why do they get in trouble there?
Let me make sure I'm not saying you don't get in trouble with the insurance company. You get in trouble with the patient because the patient says, how much is this? And you go, I don't know.
Okay, gotcha.
Right. I don't know. They don't have an answer. And what you have to do, whatever system you're going to pick, as we're going to go through, because here comes the systems and the 3 ways to do this, as far as at least we're teaching it today in 2019, is the patient's going to say, how much is this? And you need to answer it. And the way we answer it is we don't always know. Yeah, with a smile. We don't always know exactly how much they're going to cover, but Mr. Jones, here's the most it's going to cost you. We call that the maximum out-of-pocket, or MOOP is a word we just kind of came up with for that. So you have to be able to, someone in your office, and it could be the dentist or the office manager, the financial coordinator, someone needs to be able to sit down with that patient and say, for plan A, here's the most it's going to cost you. If they don't like it, we can go to plan B. There's the most it's going to cost you. Okay? If they don't like that, then we can always go to our custom fit transitional device, whatever acronym you came up with. I'll write that down. So
CD.
So whatever
Come up
that
with
is.
a
I gotta
CFTD.
write that down. I'm not that smart this late in the night. But so when we go to do this, I'm going to jump down to the bottom just to get this over with. There's different ways. Can you see my cursor there, Rich, in the
Yes.
billing
Yes.
codes? So
Uh-huh.
you can bill just for the dental device and say that's good for 90 days or 100 days or something like that, and that's all we're billing for all the appointments. And that's what we highly recommend that you do. You can also bill if you want, and you know what you're doing, which there's a big if there. It's not as easy as that. We have a whole hour webinar on out-of-network, on evaluation and management coding, which is changing as we speak. You can bill for all these individual codes each time they come in for device checks and so forth under certain situations if you cross your T's and dot your I's. We don't recommend you doing that. It confuses the patient. That's billing 505, not 101, which we're talking about tonight. So even in my office, we only bill the one code, the E0486. I think, Rich, after visiting your office last week, that's what you do too. Okay, so
Yes.
that understanding, we're going to bill one code for these patients. Now, we don't know what they're going to allow. So there's two ways of doing this. One is let the patient take the risk because we don't know. And number two is we take the risk. Okay? So let's talk.
That's a good way to put it, Guy.
Yeah,
Good
it's the
way to
first
put
time
it.
we've taught it this way.
Yeah.
Maybe each time we teach this, it gets a little bit better. So this is new if you've listened to it last time. So one way of doing that is fee for service. This is just like my dental practice ran for many years. The patient comes in, I do that little exercise, and I want $2,000, $3,000, $1,500, whatever I want. Let's call it $2,500. That makes me jump up and down and be happy at the end of the day that I got $2,500. I've helped save someone's life or improve their life. They're not snoring, they're sleeping well. They write me a check for $2,500, and we'll file everything, and they may get zero back or $2,500 back. Okay, that's one way we can do it, and that works very well. But the patient's perception is they're going to have to pay that full billable amount, and if they get anything back, it's just going to be gravy on top of that. So, that works, but you're going to get less treatment acceptance because of that.
Why would I get less treatment acceptance?
Because if I want 2,500, that's the number that's going to stick in their head. You may get 2,500 back, and you may get goose egg. So their MOOP is $2,500 or $3,000, whatever your desired amount is, because you can't.
So I have to reach in my pocket and give you $2,500. So that
right.
That
and when you get the money back later, when you get the money back later on, that didn't help you say yes 6 months ago, 3 months ago, right? It may make you happy after the fact, but it didn't help you with the treatment decision at the beginning of the treatment. Now, another way we could do is we can estimate the allowable amount. I'm going to show you a scenario on this one. And we estimate the allowable amount, and we say we're going to bill this I think the scenario I have coming up is at $3,000. That's what we want in this scenario. And don't put any numbers to this. I don't need $3,000 to make me happy in my practice to do this every day. And, some people do, some people don't. These are just numbers we're pulling out of the air. Don't go say we said this is the amount you need. You've got to figure that out for yourself, for your own overhead. But in that scenario, let's go into that, and we say, okay, patient. Oh, by the way, before we get to that, you have to have a way to estimate what the amounts are going to be in these following scenarios. Because the other ones, they pay me, what you get back a penny, you get back it all back. You don't have to really worry about it because you're kind of washing your hands of it. But we want to know, both for in and out of network, what the deductible amount is of the patient, how much is left, and what their co-pays. In other words, most insurances maybe have 70% the insurance pays, the patient pays 30%, or 60-40, 90-10, something like that. So you need a quick and easy way to do that. With DS3, Rich, I bet you've set this thing on fire in your office, right? We've got a button you can click.
It got pretty hot the other day.
We have a way of click a button that you can get all this information. Or someone can get on the phone in your office, or you can work with a third-party biller to give you this information so that you know, and this they will tell you. But again, we don't know the allowable amount. We'll know what percentages they pay and the deductible. And so this is kind of what our instant eligibility check through DS3 looks like. And by the way, again, we're about halfway through here. If anyone wants more information, we're going a little too fast, you just want help that we don't get to tonight, just type in consult, and one of our trainers will meet with you and your team, give you some free advice, help you with whatever dental sleep hurdle you have, can tell you more about how we can help you take your practices from what's your lecture, Rich? 0 to 60 at the symposium in 2.6 seconds or something like that. We can teach you how to do that. Yeah. So here's the instant eligibility check. So let's say that we desire to get $3,000, and we somehow either use an instant eligibility check or we spend a half an hour on the phone and gather that information. And we find out that their out-of-network deductible is $1,400, and then it's 70/30 coverage. Okay, we can just do some math, right? We can take the $1,400 deductible away, and now we have $1,600. So the patient's portion is 0.3. 30% of $1,600 is $480. You add that to their deductible. Their portion should be $1,880, assuming the insurance company allowed $3,000. Right, Rich? Have I done any math wrong there? Because it's late.
I think that's a busy slide, but like you said, we record these things, and you guys take a picture of that with your phone or something, because the math is really simple. We want you to understand the concept for how this works. So you're billing this amount. But again, the challenge is we don't know what they're going to allow, so we have to make some assumptions. I think you did a great job there, Guy.
All right.
So what's that number at the bottom? What's the 1880?
Well, in this billing scenario, remember, we're in the patient takes the risk scenario. So I tell the patient, all right, Mr. Jones, we've done all the math. As a courtesy to you, we're filing all this paperwork. We're going to collect $1,880 from you. And insurance is going to send us a check, likely for the difference, as long as they allow $3,000. But now, if they don't allow $3,000 for some reason, you could be on the hook for the difference between $3,000 and $1,880, which is what, $1,920 or something like that, right? So we tell them that. So now, in their mind, they're either thinking, well, I'm actually on the hook for $3,000 possibly, or what usually happens is they don't hear that second part, even though they sign a paper that says they understood it, right? So they think, okay, exactly. 1880 is the number, right? Okay, now you get the insurance check, and they decided we're going to use Medicare allowable amount in your area today because the insurance company needs to buy a new building, or whatever the reasons behind that are. Okay.
Whatever.
And so they didn't allow $3,000; they allowed 1880. And so that's actually, I mean, they allowed $1,200 rather, which was actually even less than the patient's deductible. So we essentially got no insurance benefit because we hoped that they would allow $3,000, but they didn't. And this doesn't always happen. It doesn't usually happen, but it happens. And so at this point, we're going to go back to Mr. Jones and go, remember that conversation where it was $1,880 unless, well, here's the unless, sir. You owe us $1,120.
No. You told me it was 1880.
Well, here's the piece of paper.
Right. That's what they hear, though, like you said.
Right.
So that can be an issue. It doesn't have to be, but it can be.
It can be. So you've got to be very clear if you're going to do it that way. And that works very well. You set your fee at $3,000 if that's what you want. If you want $2,000, you set it there. And that works as long as that patient gets that memo. But their actual MOOP is whatever you bill, because if you don't collect it, you're going to go back to them to get it. I guess your other option here, Rich, is you write that amount off, right? And say, well, okay, we made a mistake. But that goes to the next slide. That's where we're taking the risk. Okay, and if we do that a lot of times, we're not making our $3,000 anymore now, are we? Because we take it on the chin when we're wrong on this scenario. So I've given you two ways so far. One's fee for service. Patient pays me, checks go to them, we wash our hands of it. Number two is we estimate this amount. They understand that if we're wrong, they're taking the risk, and we have to come back to them for money, and that can cause friction at times. The third is I'm going to say, you know what, I'm going to do my best to estimate this. And if I'm wrong, I'm going to take it on the chin. Okay? And you've got to have a tolerance for getting paid a lot more sometimes and a lot less other times to end up where you want in the middle. Because if you take it down here, you've got to add it back up here, or you're never going to get to that middle part. I think that's something I don't think we've ever quite taught exactly like that. And I'm trying to make sure you understand. If you're not used to this, you do 10 cases, you may get 4,000 on some, 1,500 on others, but if that 3,000 is what you were wanting, you may end up right there in the middle. And so we're going to show you how to do a system if you want to use that system for it, because again, we don't know the allowable amount. And if you want to play this game, then you're going to have a little bit of tolerance for ups and downs and risk. Anything I missed on that, Rich? Is that
Very good. I think you did
okay?
a great job. I think that's a good way to think about looking at it too, Guy. One way, just pay me, we're done. We don't deal with insurance.
Right.
You
We
take the
can
risk
file
as a
it. We can
patient.
file it.
Yeah.
But we're not. What they pay is not our concern. So go ahead.
Yeah. Or you take the risk as the patient, or I take the risk as the dentist.
Mm-hmm.
I think that's actually a good way to explain it to the patient, Guy, because patients don't always understand that we're taking a risk in some of those scenarios. So I actually like, saying it that way. So I think you did a good job with that.
Well, great. So the way we do this 2019 in our office is we have the amount we'd really like to get on the higher end. And then we have a minimal amount that if we don't get that, we're actually kind of losing money. The minimal amount is, we're okay to do this, but we're making some money, but we can't do that on every case. Okay. And then we have what we estimate the insurance is going to allow. And then we have the worst case scenario what the insurance is going to allow. So those are the top two and the bottom two. And then in the middle is how much, if everybody was just walking off a checkbook, if we could just get rid of the whole insurance program, what would be happy just to people to give us a check? Because you have to understand, you can accept less when you're doing just a cash for this, because you're not filing insurance. You're not paying your third-party billers. There's a whole lot less hassle that goes around with it. So it is feasible to lower that amount for cash patients. Okay? So here you go. There's the secret sauce. I know it looks really confusing to some extent, and you have to understand I was an engineering firm, went to dental school, so I love this kind of stuff. But I'm going to walk you through some.
This is pretty much what we've just talked about, though.
It is, and it's not that complicated. And if you want this slide and you can't get it, take a picture of it, send us an email, we'll get it. Or again, type in consult, we'll walk through this. We have a whole billing team that can walk you through anything that we're going to miss here. But I think we're going to make it fairly quick here. So hang on just a second. Sorry about that. They're running a printer, okay, over here. So the first thing we're going to do is, if we have an insurance patient, we're going to do that instant eligibility check. And if the deductible is really high, higher than what we really want just as a cash fee, then we're just going to present the cash fee to the patient. Because what's the point in going through all this hassle to get no money for the patient? Maybe it'll reduce their deductibles, but it's really not that big of a benefit to the patient. If it's less than the cash fee, then we're going to go down the other side. So let's look at the first case scenario. We're going to keep these numbers the same throughout these two scenarios, just so we don't get confused. And again, the numbers don't mean anything. But if our office would be thrilled to have $3,000, we need $1,500 to pay the bills. And if someone just comes in and doesn't have insurance, we're happy to do it for $2,500 because we're out of a little bit of extra effort. We hope that they're going to allow the $3,000 that we're billing. Okay, but in my area, $1,070 is the Medicare allowable amount, and occasionally that's the number they choose to allow, much to our disliking. So we do the instant eligibility check on this patient, and now they have a $2,600 deductible out of network. Now they have less in network, $500. Okay, but we have a $2,600 out of network on 70/30 coverage. So as you look at this, and we have a little calculator that'll do that real quick, so it makes the math easier for you. But we do that instant eligibility check. The $2,600 deductible is greater than the $2,500 cash fee. So we're going to present them the cash fee. So the conversation goes something like this. Mr. Jones, you have a really high out-of-network deductible. They usually do know this most of the time. And we can tell them, you have the out-of-network deductible. As a courtesy to you, we have a cash fee. And, it comes with plan A. Here's what we give to you. And it's $2,500. We're just going to, not file the insurance. How does that sound? And I tell you, Rich, I used to always go over here to the gap coverage for these patients. You will be surprised at how many people, and no matter where you live, because we have people all over the country doing this, there'll be some people who will say, fine, I just want to get this done. Let's go ahead. And before I used to go straight over here to the gap coverage, now it's months later before we get to treat this patient sometimes. And I've just delayed this treatment. The patient could die. A lot of things could go wrong here. So I'm telling you, this is something new here, and at least present that to them as a possibility, as my cash fee. And you will find out some patients will say yes, and when they do, you don't have to mess with the insurance. You go down the cash fee route. If they say no, then we're going to go over here and we're going to provide for gap coverage. A gap coverage is what we apply for if we're out of network, but we want to be in network for this one case. And if there's not an in-network dental provider for the E0486 within your region, your third-party insurance billing companies can often get gap coverage. And if you recall, this patient only had a $500 in-network deductible. That's why you want to have both of them. If we can get that gap coverage, then we're probably going to be able to get this down to a cost where the patient's very happy. But you'll have to understand the amount we get is probably going to be a lot less than the $2,500 cash fee that we have over here. Hopefully it'll be enough to make us happy. That process, I'm sorry, I went too far. That process can take a few weeks to even over a month or so, and you don't always get coverage. If that fails, then we always have a provisional option to offer the patient. So as you can see by looking at this, we have an option here, even with high deductibles, to hopefully capture a patient without having them leave without being treated, at least in the long term. Rich, this is not exactly the way you do things. You're more in network. Have I lost you on any of this?
No, that's good. It is a little bit confusing. So, as you all think about this, again, don't look. You got to look at this from a little bit further back. I think as dentist guy, we're taught to look at everything like this, these right. Little up close. And with this, you just have to understand the process and the principles of who's taking the risk and, in network and out of network. I think if you work yourself through 10 or so cases, you'll have a really good idea about how all of this stuff works. So don't beat yourself up either over not knowing all of this, everything right now, right at this minute.
Right, and this is why we started out by work with a third-party biller. They will help you decide. What we're trying to let you understand is you can be in network. We already went through that. And if you're going to be out of network, there's 3 ways of doing it. Your third-party biller can't decide for you, but they can help you decide which one of those 3 paths you want to go. And they can help you put systems in place to make this flow very easily. And that's where we help. 4-Pillar Billing is our subsidiary. If you want more information, type Consultation for that too. And one of our billing experts, we have a whole room full of people that just get up every day to help people bill, and they'll help you walk through this. And I promise you, with time and decisions, because we have offices doing all 4 of those ways. We have in-network, we have fee-for-service, we have, the patient takes the risk, and then we have this model. So you have to decide what is best for you and how to go about doing it. So that's the easy scenario to some degree. They have a high deductible. Well, either gap coverage, which you could go to first, which I don't recommend. Ask for the fee-for-service first, or the custom fit a transitional device. Now this scenario here, we have a patient comes in, and again, we're going to keep these numbers the same. We'd love to get $3,000. Minimal we really need to make us pay our bills and pay everyone and make a profit is $1,500. Cash fee is still $2,500, and we estimate that they're going to allow $3,000 if everything goes well, and at that $1,070 on a bad day. Okay, and so they have $500 deductible now and 60/40 coverage, which is, you see 60/40, 70/30 most commonly in out of network. So we're going to have 2 MOOPs, maximum out of pockets. Remember that? And that's what the patient needs. And I can jump down here and say, here they are. Okay, I can tell the patient plan A is $1,500. If they don't like that, I can give them a plan B, which is a different device. Maybe not quite, maybe it's not the high-end milled device. It's a more of an EMA or something that costs less. Okay, how do I come about that? And this is where it can get confusing. If we lose you, we'll walk you through this. It's not that complicated. But I think what you want to remember is you want to have best case scenario, worst case scenario. And how we do this is you take the $3,000, you take the $500 deductible out. We have $2,500 left. The patient's responsibility is 40%. That says 40 here, right? 40 times 2,500 is 1,000. You have to add the deductible back in, right? So it's 1,000 plus 1,500. That's $1,500, assuming they allow $3,000. Okay, so if they allow $3,000 or more, even we're golden, depending on the billed amount. What happens if they only allow 1,070? Well, if they only allow 1,070, we're going to subtract the 500, and we're going to calculate the insurance benefit. Well, insurance benefit's only going to be 60% of 570, which is $342. The least we want is $1,500, so you subtract the worst case insurance benefit of $342, and you have $1,158. So those are the two numbers that we can talk to our patients about. We have a calculator that, if it's just a spreadsheet that makes those numbers pop up pretty magically. And then we can walk through this. Patient has $500 deductible, so it's less than the $2,500. We tell them we've gone and looked at your insurance benefits. Here's this device. Here's what we can do for you. We've got a nice milled device we're going to show them in the plan A, and it's $1,500. That's all you're going to have to pay. The worst case scenario, it could be better than that if insurance is even better, but that's the worst case scenario. And if they say yes, we're off and running. Now, you still need a pre-authorization, which you haven't talked about yet, very possibly. That has nothing to do with billing as far as the amount goes. If they can't afford that, then we can say, we have a plan B. Here's a different device. Here's your amount that's out of the pocket. Can you go ahead and you want to do this? If they say no, and their in-network deductibles were better, we can try gap coverage. If all that fails, we still have what is it, Rich? The custom fit transitional
CFTD.
the dental device that we can talk to them about doing. At least let's get you in this. Let's see how you feel. And if you feel like $1 million, then maybe this money will be worthwhile down the road. So again, I feel like that we've explained that as well as we have in the past. And I know it seems complicated, but you just don't look at the whole thing. Look at the path you're going down. Rich, do you have questions about that? Because like I say, I know you don't do this as often as I do, being more in network than I am.
No, but I will say, Guy, that you have to be ready for, and it's impossible to do that, but for some of the questions that the patient will ask, if the patient says, well, but this one, why does it cost less for this device? Well, it's not that that's necessarily an inferior device, but that device actually costs me less.
Right.
So I choose to pass that savings on to you. That's why I'm allowing you, I'm trying to figure out a way to treat you with you paying less money and still maintaining, a high level of treatment success and everything. So that just might be one thing I would add to that, Guy, about you have to be ready for some of these questions.
Absolutely.
Certainly don't let any of this scare you away.
Right.
I understand there's a learning curve. Understand that you gotta jump in and you just gotta start doing this. And again, you don't have to do it by yourself. You don't have to reinvent the wheel here.
Right.
Third-party billers help you do this, and they can really help you get going with this.
Yeah, and one thing that I want to emphasize is I don't do this. The patient's coming in for consultation. We do the instant eligibility check. I take the risk as the model I use in my practice because I think that's the way most people say yes to treatment. And we go through that system, what we just said, and my team does this, and they make a note in DS3 that has the high and the low MOOP. So all I have to do is look at this, or my financial coordinator, and say, okay, you want to do this? We have 3 options for it. Ideally just said, here's what we'd like to do. Give them option A, and if they say no, then we can go to B, and then we can go to the custom fit transitional dental device after that. And we go through those, and it's not just the device. We give a little further, more long-term care, a little, the first annual recalls included with option A. So you can add things that you give that are value to make one option a little, truly mean more than the other, while still all 3 are good services for what you're charging, what your fees are. So I know what those fees are. We're not sitting there doing this in front of the patient. Before they ever walk through the door, we've got this all noted. So remember that some key things I say is, if I'm going to be on the roller coaster, look, I'm taking the risk here. I'm going to accept your insurance no matter what they allow. And the most you're going to have to pay is this. And they need to, they like it when they hear that. Say, your billable amounts, whatever it is, but I'm going to accept whatever they allow. When we get the EOB back, we do accept whatever they allow. We write off the difference because you don't have to collect anything above what insurances allow, certainly. And we make sure these things are in writing so that the patients fully understand them. I don't want to talk in detail about Medicare because we're running a little bit behind. So what I'm going to say about this, Rich, is that you should become a Medicare provider. And if you do become a Medicare provider, you don't have to accept the full amount that Medicare gives you. And I'm just going to kind of go over here to, I'll just pause on these. These are the Medicare allowable amounts in each region, and 80% of those are gone to the patients. And if you want these, we'll be happy to send these to you. Here's where Rich and I live, in the least reimbursed area. I don't know why we picked there, because it's warm maybe. And here's we go. But as a non-participating Medicare provider, a patient can come in your office and the checks can go to the patient and you can bill the patient what you like. And I know some questions came up about Medicare, so I really want to get this. You need to fill out this advanced beneficiary notice. I'm just going to go to the slide right here and explain this to you. For a Medicare patient, they come in the office, we know how much they're going to allow for the most part. In Florida, it's $1,069, and most people, that's 800 and change, they're going to get from Medicare, and most people have supplemental insurance that's going to pay a couple $100. So if I want more than the $1,069, I can just tell the patient how much it is I need. They pay me, and the checks go to the patient. Okay, that's one way of doing it. If you decide that you can accept less than that, because there's more than one Medicare allowable device, and some of them have less lab fees on them than others, we can have an option B where maybe that amount I need is less. And in the worst case scenario, if I can accept the $1,069 from Medicare, and the checks come to me, and the patients pay nothing in almost every case. So with Medicare, there's really no reason to not get most patients into care, as long as you can live with this accept assignment of benefits in some cases. Richard, anything on that you want to clarify? Because I know that we're running a little bit out of time, and I don't want to leave people hanging here.
Great. You always ask me when we're out of time. You ask me, hey, anything else?
We got 4 minutes, so go ahead. The floor is yours.
I'm kidding. The only time I do that, guy, is, a little old lady comes in and I just fall in love with her. And, I know she doesn't have any money. And I go, yeah, I'll accept assignment of benefits. You have a secondary. It doesn't cost you anything. And I feel good about doing that. I want to feel good about treating people. So I think at the end of the day, that's not unreasonable. It's not unreasonable to want to treat people and to be able to make a living at this. Somehow we've come from the rich doctor to the bad doctor that wants to actually make a living, because of this. And we need to learn to stand up. And I think you did a great job, Guy, of putting all this stuff together to try to help all of us figure out, how we do the checks, what's in network, what's out of network, how much the deductibles are, and then how we determine that maximum out of pocket for the patient, because patients want to know what it's going to cost. So one of the things you said earlier, Guy, was, if I'm the captain of the ship and you go, what do you think we should do, Captain? I don't know. You never say I don't know when you're the captain. You always have an answer. So that's why as a team, you guys need to talk about this, and you need to figure out which billing systems we're the most comfortable with and how we want to do this, and give yourself some latitude, because things change. Things change. Insurance companies change. Reimbursement changes. Allowable amounts change. So be a student of this and understand that we're doing this to help the patient.
Absolutely. And by the way, we'll stay on. I see a lot of questions coming in. I want to respect everyone's time that took the time tonight to, and we'll stay till the questions are answered. So just to understand that, a lot more questions about Medicare, and if you want more help with this, let us know. Type in consult. One of our 4-pillar billing team members will get with you. If it's about something else, dental sleep, we'll get to it too. I think I've gone through this with the Medicare. Essentially, in my office, these aren't the exact numbers, but we still have a plan A and B for Medicare, and because we know that Medicare will allow a certain amount, and the patients, we collect the amount that the patient's going to be out and above Medicare, and we know that the 1,070 is going to go back to them regardless, and we can, if we wanted 2,070, well, then we'd collect $1,000 from them. If we needed more than that, we collect more than that. If we needed a plan B where the device is a little less expensive, we can do that as well. Medicare, if you are worried about Medicare, I can actually say it's easier than out-of-network billing, because we know the allowable amounts in most cases. So the bottom line is, as we do this, we're just trying to make it so the less the patient has to pay out of pocket, the more cases you're going to do. And I think, on one case it's simple. I just charge you what I want. Checks will go to you if you get what you get. You don't have a fit, like I used to tell my son when he was a little younger. That's fine, and that will work, and that's simple. And I think that's the appropriate billing model for some offices. Understand, you will do less cases than the guy down the street who works with medical insurance, takes some risk, gets medical billing and gets referrals from physicians and so forth. So, really just, you have to find your own balance. And I think the reason this is complicated to some people is because it's not the same for everybody. Rich is in network with 3 providers, I think you are. I'm not in with five providers he is. I'm not with any right now, and we're still doing well. We recommend everybody at least being non-participating in Medicare, but there's a lot of different ways of doing this. And we don't want to come across self-serving, but we can honestly tell you, you will not succeed without help if you're new to this. That's what we do through DS3. We have a system where you input the patient data. Actually, the patient inputs the data. You click buttons. We process the claims, and the results come right back in DS3. If you want to know more about how we can just streamline this process, just contact us, type consult, email us, let us know that you're interested in learning more about that process, because if you try to do it by yourselves, you're not going to be these happy faces here. You're going to have a lot of grumpy people going, "Oh my God," pulling their hair out, because it's difficult to do. So,
I think, guys, sometimes that's what happens to dental offices, and they get turned off and they get a really sour taste in their mouth, because they don't understand this, and then they kind of get in it and they're like, "Man, I made 3 dental devices now and I haven't been paid anything, and then the insurance doesn't pay me." That is the last thing in the world that we want to have happen to you.
Right.
That's why we're spending our evening here trying to teach you guys how to do this so that doesn't happen. But put together all of this stuff and talk about it as a team, decide, the American Dental Association came out, Guy, in October of 2017, wasn't it? Or was it 18? Maybe I'm getting old.
With the new
where
parameter?
They said, where we need to be, it was 2017. So I polled all of the dentists in Ohio last Friday, and about 25% of them never even knew that. They didn't even know that as a dentist we're supposed to be screening for sleep disordered breathing. So, we need to be catching this in our practice. We're at such a pivotal position in across the country, because more patients see their dentist more frequently than patients see their medical doctors. And so we're in such a great position to screen for this and get more people into the funnel and get more people treated.
Yeah, and we have a solution to help with all aspects: screening, testing, treating, billing, to help your practices do this. It has taken us 20 years between the two of us to get to the point where this is a fluid system that works well, and we're committed to even making it better daily. It's better than it was a year ago, better than it was 2 years ago, and we're continuing to make it easier for dentists to succeed in dental sleep. If you want to know more about what we do, certainly just email us, type in consult. Don't forget about the courses. If you want the discount on the course, type course and you get $200 off. We're only offer that on these webinars, so because $9.95 is a good, very fair fee, if not under amount to start with. So type in course if you're interested in any of them in 2018. And here's something for free. We like to give something for free: Dental Sleep Insider magazine. We put this out once a quarter. If you're not already subscribed, just type that subscription in, or just go there and sign up, and you can see all the back issues. And it's very, very practical. It works. We work with many of the key opinion leaders throughout the country. We get articles about everything from how to make a edentulous upper device to billing to I don't know, what was your last article on, Rich? It's always good. We got lots of things in there. So, and it's free. So you can't be, oh, there's the course. I want to make sure we still had those in there. We're adding other ones on there as well. For even at $9.95, it's a great deal. It's all day Friday. We even take you to dinner Friday night. So you will be happy you came. There's no course like this as far as how you actually do this in your practice. We focus on strictly implementation. This is the systems.
And I will say also, Guy, about the courses. Remember, these are 2-day courses, and you get to take a home sleep test home with you, the first night if you want, and then you get a dental device. I think every dentist should undergo a home sleep test, and I think every dentist should have a dental device and wear it at least occasionally. I mean, you don't have to have a root canal to understand what it's like to go through a root canal, but in this particular instance, undergoing a sleep test and wearing a dental device, you're part of that club again. There's something about human nature that when we're part of this and we do this, that really seems to make a difference. So, there's some of you out there, and there's some staff people that are thinking, wow, I might have sleep apnea. I never knew some of this stuff. Well, the course is the cheapest way I know to actually get, a sleep test and a treated. So it's not a bad deal. Plus, you get some education that's pretty dang good.
They're very worthwhile. I see a question. We're getting all your questions. No, we don't. If people have questions about the pharyngometer, we can certainly can talk about it. Our courses spend most of the time focused on workflow and how you go. We really break it down after the first part. The first hour and a half is all the science and everything that you're going to get in all the other courses, and then from the break on the morning of Friday till Saturday afternoon, it is literally each treatment step that you go through and what you need to do, what your team needs to do, systems you need to have in place, verbal skills you need to say, and every step along the way you need to do this profitably, to do it efficiently, and in such a way that you provide a very superior treatment outcome. Because I think that's where we get lots of us get confused. We make these devices, we don't know what to do afterwards. And so I promise you come to the course, you will leave with more knowledge than you can get about anywhere else. So there's how you get in touch with us. If you typed in course or consult, we will get in touch with you. We're not.
I think the team's doing a fantastic job, Guy, of going through all the questions and answering a lot of this stuff. So again, I guess, I was doing a lunch and learn yesterday, Guy, and in the physician's office, there was a big plaque up on the wall, and it was a quote from Abraham Lincoln, and it said, "Whatever you do, be good at it." And I actually took a picture of it, and I thought, wow, sometimes the most simple things are the most profound. And I would just encourage you, as you think about doing dental sleep medicine, don't dabble. Just decide. If I promise you, if you made it into dental school and you graduated, you are smart enough to figure out how to do this. Don't beat yourself up over it, but you don't have to reinvent the wheel either. Just become a student of it. Learn, look at all this stuff, read what you can, go to courses. There's a lot of courses out there. Of course, we're a little biased, aren't we, Guy? Because ours focuses so much on the treatment steps, and what we do, because again, we're practical. Guy and I both do this. We put gloves on every day. We're still treating patients. We're doing this. And, I do a whole lot of this in my practice in San Antonio. For those of you who are doing this and you want to come visit an office and look at this and see how this stuff kind of goes, we have programs where you can do that too. You can make those visits, and we make that open to the doctor and one staff member. And we've never had anybody do that who didn't think it was one of the best things they ever did.
It's the best experience for the money that there is. So if you're interested in that, you can let us know as well. But I want to emphasize what Rich said, not dabbling, but I want to also make sure that you don't get the wrong impression. This isn't something you have to do full time. We don't want most of you to do it full time because we need dentists. I did this for many years, not as a dabbler, but I did it as a dabbler for many years too first before I realized, all the steps that we need to do to put together. But for many years, I ran my restorative practice and this at the same time. What Rich is talking about is you need a certain amount of education and systems to make this so that you go in one room and you do a crown prep, and you go in the next room and you seat an implant crown, and you go in the other room and you deliver a dental device, and it just goes just that smooth.
And you don't miss a step. You don't run into the wall or have to go outside and smoke a cigarette, before you go in to do the dental device. I thank you for clarifying that, Guy. I didn't mean to say, don't dabble, but just be good at it.
You be good at it. And the good news is I've done all those other things. I've done root canals. I became pretty good at those. I became really good at dentures. I became very good at prosthetics. And this, with the systems that we have, you can become a non-dabbler, so to speak, in a matter of a few months. As a matter of fact, I'm going to say one last thing before we get off here. I have a new associate I got in August. I had an associate for 2 years. I'm so busy, the majority of patients my associate sees. And he went from not knowing what dental sleep medicine was at his interview, came and shadowed my office for 2 days and said, "This is the most amazing thing I've ever seen. I want to do this. All your patients love you. I'm happy. I'm excited." He didn't know what AHI was. He didn't even know what a dental device was. 6 weeks later, he was seeing the vast majority of the patients because we could teach somebody to do this and not be a dabbler because there are systems out there. So anybody else has any other questions? That's what we do. No one does what we do in the country. I see someone saying they want to come see you, Rich. I don't. Rich is probably going to send me a bill. I spent 2 days with him last week, and I can tell you, even from my experience, because I'm not quite as busy as Rich is there, he's got a system going on there that's worth seeing. So, Dr. Murphy, you'll be very happy you went there. I see on there as well. So, I'm looking at all the things that we got into everything.
Somewhere up there, Dr. Parvani said you are amazing, and I didn't know if he was talking to me or you, Guy.
Oh, it was me.
The staff people. It was you. Okay.
Been a day and a half, buddy.
Yeah. See you. Thank you, guys. Have a good evening.
All right. Let me see if I can find the off button here.